Sing one note, right now. Any note you like, just pick one and hold it for as long as your breath lasts. And while you are holding it, I want you to pay attention to something very specific. Not the sound, not your throat. I want you to pay attention to what is happening behind your ribs, in the space where your lungs wrap around a muscle that has been beating since before you were born. You felt something shift in there. The rhythm changed. Just for a second, the spacing between the beats was different. Now, most people would say, well, that is just breathing, that is just the mechanics of the chest moving around. And they would be partly right. But the real story, the one nobody tells you, is about a nerve. A single nerve that runs from your skull all the way down through your chest and into your gut. And that nerve is the reason your heart just did what it did. Let me show you what I mean. There is a nerve in your body called the vagus nerve, and it is the longest cranial nerve you own. It starts at the base of the skull in the brainstem at a cluster of neurons called the nucleus ambiguus. From there it runs down through the neck, threading between the carotid artery and the jugular vein, and it passes through the chest cavity where it sends branches to the heart, the lungs, the stomach, the intestines, the liver, the spleen. The word vagus is Latin for wandering, and that is exactly what this nerve does. It wanders farther from the brain than any other cranial nerve. Now here is the thing you need to understand about it. 80% of its fibers are sensory. They carry information upward, from your organs to your brainstem. They are reporting on pressure, on stretch, on chemical states, on what is happening mechanically in every organ they touch. The remaining 20% carry commands downward. And the most important command the vagus delivers to your heart is, slow down. Your heart has a built-in pacemaker, a small strip of specialized cells in the upper wall of the right atrium called the sinoatrial node. These cells fire spontaneously. They do not need the brain to tell them to fire. Left alone, the sinoatrial node would beat at about 105 times per minute. That is its intrinsic rate. But the vagus nerve releases a neurotransmitter called acetylcholine directly onto those pacemaker cells. Acetylcholine binds to muscarinic receptors, opens potassium channels, and slows down the depolarization rate. It pulls your resting heart rate from 105 down to somewhere between 60 and 80, and it does this fast. Within 150 milliseconds of vagal firing, the heart slows. Compare that to the sympathetic system, the accelerator, which takes 30 to 60 seconds to reach full effect through norepinephrine. So every heartbeat you have ever felt has been a negotiation. The node wants to go faster. The vagus holds it back. And the strength of that holding back, that is what we call vagal tone. High vagal tone means the brake is strong, the heart is flexible, the resting rate is low. Low vagal tone means the brake is weak, the heart runs fast and rigid. And low vagal tone, measured as reduced heart rate variability, is one of the strongest independent predictors of cardiovascular mortality. It predicts death more reliably than many of the blood tests your doctor orders. So the question becomes, how do you strengthen the brake? And the answer, it turns out, has been hiding in something so ordinary that nobody thought to measure it until recently. When you sing, you exhale longer than you inhale. Think about what happens. A normal resting breath cycle is about 4 seconds. 2 seconds in, 2 seconds out. 12 to 20 breaths per minute. But when you sing a phrase, the exhalation extends to 6, 8, maybe 12 seconds. The inhalation compresses into a quick 2-second gap between phrases. You end up breathing at a rate of about 6 complete cycles per minute. 1 breath every 10 seconds. In physics terms, that is a frequency of 0.1 hertz. Now, why does that particular number matter? Because your cardiovascular system has its own built-in oscillation. There is a rhythm in your blood pressure that rises and falls independent of breathing. It is called the Trobe-Herring-Mayer wave, named after the 3 physiologists who described it, and it cycles at approximately 0.1 hertz. This wave reflects the operation of the baroreflex, the feedback loop, by which baroreceptors in the aortic arch and carotid sinuses detect blood pressure changes and signal the brainstem to adjust heart rate. The baroreflex has a resonant frequency, and that resonant frequency is about 0.1 Hz. When your breathing rate drops to 6 breaths per minute, it matches the resonant frequency of the baroreflex loop. The two oscillations lock together. Respiratory phase, blood pressure phase, and heart rate phase all synchronize into a single wave. We call it cardiovascular resonance. The amplitude of heart rate variability shoots up, not because the heart is unstable, but because the system is oscillating at the frequency where energy transfers most efficiently between respiration and circulation. Now, if you know anything about physics, you know what resonance means. Every oscillating system has a natural frequency at which it absorbs and transfers energy most efficiently. Push a child on a swing at random intervals and nothing much happens. Push at the natural frequency and the amplitude grows with each cycle for essentially zero extra effort. That is resonance. Your cardiovascular system has this property. The baroreflex feedback loop, which bounces signals between the baroreceptors in your arteries and the vagal motor neurons in your brainstem, has a delay built into it. The signal goes up, gets processed, comes back down. That round-trip delay sets the natural period of the loop at about 10 seconds. 0.1 Hz. When your breathing matches that period, every exhale arrives at precisely the moment the baroreflex is ready to amplify the vagal response. The system does not fight itself. It builds. Let me walk you through the mechanics of one cycle. When you breathe in, the diaphragm contracts and drops into the abdominal cavity. Intrathoracic pressure falls. That negative pressure draws blood from the inferior vena cava upward into the right atrium, filling the heart. At the same moment, the reduced pressure releases mechanical compression on the vagus nerve, and pulmonary stretch receptors in the expanding lungs send inhibitory signals to the vagal motor neurons in the brainstem. The vagal brake lifts. Heart rate goes up. When you breathe out, the diaphragm relaxes and rises. Intrathoracic pressure increases. Venous return slows. Baroreceptors in the aortic arch detect the pressure change and fire afferent signals up the vagus to the nucleus of the solitary tract in the medulla. The brainstem responds by increasing vagal efferent output. Acetylcholine hits the sinoatrial node. Heart rate comes down. This acceleration on the inhale and deceleration on the exhale is called respiratory sinus arrhythmia. Carl Ludwig described it in 1847. It is not a disorder. It is the opposite. It is your heart demonstrating flexibility, proving that the vagal brake can engage and disengage rapidly, adjusting cardiac output to the changing pressure environment inside your chest with every single breath. And there is something else embedded in this rhythm that most people never learn about. Junichiro Hayano and Fumihiko Yasuma, two physiologists in Japan, published a study in Circulation in 1996 that changed how we think about this. They built a canine model where they could artificially generate or eliminate the heart rate oscillation while holding the breathing rate constant. When they imposed a pattern matching normal respiratory sinus arrhythmia, speeding the heart during inhalation and slowing it during exhalation, the ratio of dead space to tidal volume decreased and oxygen delivery increased. When they inverted the pattern, gas exchange deteriorated significantly. What does that tell you? The heart is not just varying its speed as a passive byproduct of pressure changes. It is actively timing its output to match the moments of maximum oxygen availability in the lungs. When you inhale and the alveoli fill with fresh air, the heart beats faster, pushing more blood through the pulmonary capillaries at exactly the moment there is oxygen to collect. When you exhale and the alveoli are emptying, the heart slows, conserving effort because there is less oxygen to extract. Respiratory sinus arrhythmia is an efficiency engine, and it runs best at 6 breaths per minute. Björn Vikhoff at the Sahlgrenska Academy at the University of Gothenburg put this together with singing in a beautiful experiment. He brought 15 18-year-olds into a lab and had them do 3 things. Hum a single tone with free breathing. Sing a Swedish hymn, Härliga Jorden, with partly guided breathing. And chant a slow mantra, deliberately composed so that each phrase plus the inhalation that followed lasted exactly 10 seconds. 0.1 hertz. The humming produced heart rate variability, but at different frequencies for each singer because everyone chose their own breathing pauses. The hymn produced more coherent variation, with peaks at the hymn's phrase frequencies. But the mantra did something extraordinary. Every singer's heart rate oscillation locked to 0.1 hertz. Their hearts accelerated and decelerated in unison. 15 individual cardiovascular systems beating as one, driven by a melody that structured their breathing at the resonant frequency of the baroreflex. Published in Frontiers in Psychology, 2013. Vikhoff put it plainly. Singing regulates activity in the vagus nerve. Songs with long phrases achieve the same effect as breathing exercises in yoga. Through song, we can exercise control over autonomic states that are normally beyond voluntary reach. So the melody is a breathing template. The breathing template is a vagal pump. The vagal pump is a cardiovascular oscillator. Singing is not something that happens alongside breathing. Singing is a breathing prescription that happens to produce sound. But wait. The vagus is not responding to the breathing alone. There is a second mechanism here, and it comes from the act of producing voice itself. When your vocal folds come together in the larynx and vibrate, they create resistance in the airway. Air does not just flow out freely during singing the way it does during a passive exhale. It meets obstruction. That obstruction produces micro-oscillations in intrathoracic pressure that propagate outward through the tissues of the chest. The vagus nerve passes directly through this pressure field. Its trunk runs alongside the trachea, millimeters from the larynx. And here is the anatomical detail that makes this inescapable. The recurrent laryngeal nerve, a branch of the vagus itself, loops down from the neck into the chest and then back up to innervate the muscles that open and close the vocal folds. In a giraffe, this nerve travels all the way down the neck, loops around the aortic arch, and then travels all the way back up, several feet of nerve to reach a destination inches away. It is, from an engineering standpoint, absurd. It is a leftover from our fish ancestors, where the path was direct. But from our standpoint today, what matters is this. The vagus nerve controls the vocal folds and is simultaneously stimulated by the vibration those vocal folds produce. It is both the sender and the receiver. The nerve that makes you sing is the nerve that listens to you singing, and it forwards the message directly to your heart. This is where singing becomes something that simple, slow breathing cannot replicate. Luca Bernardi and colleagues at Concordia University in Montreal tested this directly. They compared cardiorespiratory physiology in 20 healthy adults across 4 conditions. Singing familiar slow songs, improvised vowel vocalization, a practice called toning, and 2 matched silent breathing conditions where participants breathed at the identical rate but made no sound. Published in Scientific Reports, 2017. Toning slowed respiration to almost exactly 6 breaths per minute and significantly improved heart rate variability compared to baseline and regular singing. But the finding that matters most is this. Heart rate variability was higher during the vocal conditions than during the silent breathing conditions matched for the same respiratory rate. The voice added something the breath alone could not account for. Bernardi attributed this to the mechanical and sensory effects of phonation. The vibration, the subglottic pressure, the fluctuating airway resistance, the micro-oscillations in intrathoracic pressure generated by vocal fold contact. Each of these creates a physical signal that the vagus nerve is positioned to detect. So if you breathe at 6 cycles per minute, you get 1 level of vagal activation. If you sing at 6 cycles per minute, you get that same level plus a second layer of stimulation from the vibration itself. Now the effects reach beyond the heartbeat. They reach into the walls of your blood vessels. Jacqueline Kolinsky, a cardiologist at the Medical College of Wisconsin, recruited 60 patients from cardiology clinics, average age 61, 68% women. Average body mass index 32. These were not healthy young volunteers. These were people with established cardiovascular risk. She had them sing along to a 14-minute instructional video and measured two things before and after: heart rate variability and vascular endothelial function, measured with peripheral arterial tonometry at the fingertips. Let me explain what that second measurement means, because it is important. The inner lining of your blood vessels, the endothelium, is not just a passive tube. It is an active organ. When blood flow increases through an artery, the healthy endothelium senses the shear stress and releases nitric oxide. Nitric oxide is the molecule that earned Robert Furchgott, Louis Ignarro, and Farid Murad the Nobel Prize in Physiology or Medicine in 1998. It diffuses into the smooth muscle of the vessel wall, activates guanylate cyclase, produces cyclic GMP, and causes the muscle to relax. The artery dilates. More blood flows through. This is reactive hyperemia, and it is how your body matches blood supply to demand. When the endothelium is damaged or stiff, it releases less nitric oxide. The vessel does not open properly. Blood flow meets resistance it should not be meeting. That resistance, sustained over years, is the machinery of atherosclerosis. And there is a second nitric oxide pathway that connects directly to the vagus. Research on vagus nerve stimulation has shown that vagal firing triggers nitric oxide release in cardiac ventricular tissue through a mechanism independent of the muscarinic receptors that control heart rate. The vagus has two separate ways of protecting your heart. One slows the pacemaker. The other releases a vasodilatory, anti-inflammatory molecule directly into the heart muscle. After 14 minutes of singing, Kulinski found that the Framingham Reactive Hyperemia Index, the measure inversely related to cardiometabolic risk, increased significantly from 1.88 to 2.10. Published in Frontiers in Cardiovascular Medicine, 2022. The improvement was comparable to what you would see after a short bout of moderate intensity exercise. Now think about who this finding is for. The 68-year-old in the cardiology waiting room who has been told to exercise more, who has arthritis in both knees, diabetic neuropathy in the feet that makes walking to the mailbox painful, who lives 14 miles from the nearest cardiac rehabilitation center. Among Medicare beneficiaries over 65 who qualify for cardiac rehabilitation, only 24% ever attend a single session. Not 24% who complete the 12-week program, 24% who show up once. 3 out of 4 people who qualify for the best secondary prevention we have in cardiovascular medicine never use it. That is not a compliance problem. That is a delivery problem. The intervention works. The patients cannot reach it. That person can sing, sitting in a chair, for 14 minutes, no equipment, no gym, no copay, no transportation required. And the cardiovascular system does not care how the diaphragmatic compression was generated. It does not ask whether the rhythmic intrathoracic pressure change came from a treadmill or a hymn. It responds to the pressure, the vagal input, and the endothelial shear stress. The blood vessels respond to the physics. They responded regardless of whether the person was a good singer or a bad one, regardless of whether they enjoyed it, regardless of whether they had ever sung before. Kulinski's sub-analysis, published in 2025, showed the response was largest in patients with the worst baseline endothelial function. The sicker the vessels, the bigger the improvement. The endothelium responded to the physics of the act, not the quality of the performance. Now I want to go one level deeper, because the vagus does not only talk to the heart and the blood vessels. It talks to the immune system. There is a circuit called the cholinergic anti-inflammatory pathway, first described by Kevin Tracy at the Feinstein Institute for Medical Research in 2000. When vagal efferent activity is high, the vagus releases acetylcholine at the celiac ganglion, which relays the signal to the splenic nerve. At the spleen, Acetylcholine binds to alpha-7 nicotinic receptors on macrophages and suppresses the production of pro-inflammatory cytokines. Tumor necrosis factor alpha. Interleukin 6. Interleukin 1 beta. These are the molecules that drive chronic low-grade systemic inflammation, the kind that eats away at arterial walls, destabilizes plaques, and remodels the chambers of a failing heart over months and years. When vagal tone is high, the inflammatory brake holds. When vagal tone drops, the brake weakens and the immune system runs hotter. Heart failure is defined by exactly this autonomic signature. Sympathetic drive is chronically elevated. Vagal tone is chronically suppressed. Pro-inflammatory cytokines circulate at levels that actively damage cardiac tissue. The ratio between the accelerator and the brake is tilted toward inflammation, toward remodeling, toward deterioration. Restoring vagal tone does not just slow the heart down, it turns down the fire. And that understanding is what led cardiologists to build one of the most expensive interventions in modern cardiovascular medicine: the implantable vagus nerve stimulator. It is a titanium pulse generator about the size of a stopwatch, placed under the skin below the left collarbone, connected by a lead wire to a helical electrode wrapped around the left cervical vagus. It delivers periodic electrical impulses, typically 5 to 20 Hz, pulse widths of 250 to 500 microseconds, at current levels calibrated to engage vagal fibers without causing dangerous heart rate drops. The Anthem-HF trial implanted these in 59 heart failure patients and showed improvements in heart rate variability, ejection fraction, and 6-minute walk distance. The Innovate-HF trial, the largest ever conducted, enrolled 707 patients across multiple centers to test whether the device could reduce death and heart failure events. The results were mixed. Innovate-HF did not hit its primary endpoint for mortality, but it did show improvements in quality of life, functional capacity, and New York Heart Association class. The failure likely had more to do with stimulation dosing than with the concept itself, which is why a new pivotal trial, Anthem-HFrEF, is specifically designed to test whether higher intensity, physiologically confirmed vagal engagement can do what the earlier trials could not. The device costs about $10,000. The implantation surgery adds another $10,000 to $20,000. Battery replacements every 5 to 8 years, programming visits, complication management, the known side effects of hoarseness and vocal cord dysfunction from the electrode sitting on the very nerve that controls the larynx. Over a decade, the total cost reaches $40,000 to $60,000. The molecular target of this device is acetylcholine release at the vagal terminals. The goal is increased vagal tone. The downstream effects are modulation of the sinoatrial node, improved heart rate variability, improved sympathovagal balance, suppression of pro-inflammatory cytokines. The molecular target of singing is acetylcholine release at the vagal terminals, through respiratory-driven and phonation-driven activation of the same nerve, using the same neurotransmitter, engaging the same receptors. I want to be very careful here, because this is the point where it is easy to get carried away. The dose is not the same. A surgically implanted device delivers continuous, precisely calibrated electrical stimulation optimized over multiple clinical trials. It can be titrated. It works during sleep, during silence, during every hour the patient is alive. Singing delivers intermittent, variable intensity vagal activation that stops when the music stops. The device exists because there are patients whose vagal tone is so profoundly suppressed, whose hearts are so structurally compromised, that no behavioral intervention can restore the balance. Those patients need the device. But the pathway is identical. The nerve is the same nerve. The neurotransmitter is the same molecule. The receptor on the pacemaker cell is the same receptor. A $40,000 titanium generator sutured to the cervical vagus and a 10-minute song in a living room chair are separated by orders of magnitude in clinical potency, but they are not separated by mechanism. They are two delivery systems for the same physiological instruction sent through the same nerve for the same cardiovascular purpose. Now let me tell you what we know with confidence and what we do not, because I never want to sell you certainty that the evidence has not earned. And in science, if you are not honest about what you do not know, you are not doing science. You are doing advertising. The respiratory mechanism is bedrock. Slow breathing at 6 cycles per minute increases heart rate variability, enhances baroreflex sensitivity, and engages cardiovascular resonance. This has been replicated dozens of times in healthy adults, in cardiac patients, in athletes, across different countries and measurement technologies. The link between singing and slow breathing is anatomically direct and has been measured repeatedly. Song phrases extend exhalation. Inhalation occurs between phrases. The breathing rate falls naturally into the resonant frequency range. That part is solid. You can take it to the bank. The phonation effect, the additional vagal stimulation from voicing compared to matched silent breathing, rests primarily on Bernardi's toning study and the anatomical proximity of the vagus to the larynx. The data support it. The physiology makes sense. But the number of studies isolating this specific component from the respiratory component is still small, and the effect size, while statistically significant, is modest. I would call this plausible and supported, but not yet definitive. More work needed. The vascular endothelial findings from Kulinski's group are clinically exciting but methodologically young. The initial pilot had 60 subjects and no control group. That is a starting point, not a conclusion. The subsequent randomized, researcher-blinded crossover trial in older adults with coronary artery disease, published in Frontiers in Cardiovascular Medicine in 2025, added a 30-minute rest control and a music therapist-led singing condition. That is the kind of study this question deserves. The field is maturing. But the optimal dose, the persistence of the effect beyond the acute measurement, and the long-term clinical impact on cardiovascular events are still open questions. The anti-inflammatory pathway through the cholinergic reflex is well established for electrical vagus nerve stimulation. Kevin Tracy's work made that clear. But the activation of this specific pathway by singing has not been directly measured in a human study. Nobody has drawn blood before and after singing and measured cytokine levels in a controlled design with enough power to be conclusive. The inference follows from the chain. Singing increases vagal tone. Increased vagal tone activates the cholinergic anti-inflammatory pathway. Therefore, singing likely modulates inflammation. Each link has evidence behind it. The full chain from singing to reduced tumor necrosis factor alpha has not been tested end to end. It is a reasonable inference. It is not yet a finding. The oxytocin pathway is the weakest of all. Günter Kreutz at Karl von Ossietzky University in Oldenburg found increases in salivary oxytocin after group singing. Arla Good and Frank Russo at Toronto Metropolitan University found that group singing, but not solo singing, elevated oxytocin and mood. But Schlatt and colleagues at the University of Regensburg found that salivary oxytocin actually decreased during both choir and solo singing. Those findings directly contradict each other. The social context, the measurement method, the timing of sample collection, and individual variation all seem to determine which direction the result goes. I would not build a clinical recommendation on this pathway. Not yet. Maybe not for a long time. Here is what stays with me when I put this all together. Cardiovascular disease kills more people every year than cancer and chronic lung disease combined. Lifetime risk is close to 50% for a 30-year-old with no diagnosis. Cardiac rehabilitation, the best secondary prevention we have, reaches fewer than 1 in 4 eligible patients. Exercise requires mobility. Gyms require money. Rehabilitation centers require transportation. Long-term compliance defeats most programs within 6 months. Singing requires a diaphragm and a larynx. It costs nothing. It works seated, lying down, or standing. It needs no equipment, no referral, no insurance authorization, no physical capacity beyond the ability to breathe and make sound. It produces measurable improvements in heart rate variability, vascular function, and autonomic balance within minutes. Not after a loading dose, not after a titration period, within the duration of a single song. This does not make singing a replacement for medications or cardiac rehabilitation. The severity of the disease matters. Anyone who tells you singing cures heart disease is confusing a mechanism with a miracle. But the mechanism is real. The nerve is real. The acetylcholine is real. The shift in sympathovagal balance has been measured. And the fact that this mechanism has been hiding inside something humans have done in every culture, on every continent, for tens of thousands of years before anyone held a stethoscope to a chest, that is not a coincidence. That is natural selection leaving a fingerprint. Think about what singing actually demands from the body. Deep diaphragmatic inhalation followed by prolonged controlled exhalation against airway resistance. Sustained phonation generating intrathoracic pressure oscillations. Rhythmic repetition that entrains breathing to a regular frequency. Vibration in the tissues surrounding the vagus nerve. Simultaneous suppression of sympathetic tone and enhancement of parasympathetic output. No other voluntary behavior combines all 5 of these inputs at once. Running raises sympathetic tone. Meditation slows breathing but generates no vibration. Yoga breathing exercises come close but lack the sustained vocal fold resistance. Singing is the only voluntary act a human can perform that simultaneously controls breathing rate, generates airway resistance, produces mechanical vibration along the vagal trunk, and does all of this at a frequency that matches the cardiovascular resonance point. And we find it everywhere. Every culture that has ever been documented sings. Hunter-gatherer groups in the Kalahari sing. Monasteries in Tibet chant. Gospel choirs in Alabama sing. Mothers on every continent sing to infants who cannot understand the words. The ubiquity of singing across human cultures is one of the strongest pieces of evidence we have for a biological basis. If it were merely cultural, we would expect to find cultures that never developed it. We do not. Every group sings. And now we know what the singing is doing to the nerve that runs from the brainstem to the heart. The cultures did not know the mechanism. But the selection pressure was real, and it favored the behavior. Your grandmother knew this. Not the biochemistry, not the nerve, not the resonant frequency or the baroreflex loop or the muscarinic receptors on the pacemaker cells. She knew none of that, but she knew the outcome. She sang in the kitchen while she cooked. She sang in the car with the windows down. She sang in the church on Sunday morning and hummed while she folded laundry on Sunday afternoon. And when you were upset, when your heart was racing and your hands were shaking and you could not sleep, she did not hand you a prescription. She told you to sing along. She was writing you a cardiovascular prescription in a language older than medicine, in a language older than language itself. And your old family doctor, the one who retired before electronic health records, who told his patients with high blood pressure to join the church choir, who told the anxious widow with the racing heart to hum while she cooked dinner, who had no clinical trial to cite and no p-value to present, and would have been dismissed at a modern evidence-based medicine conference, because he could not produce a randomized controlled trial. He was describing the same molecular intervention that cardiologists at the Medical College of Wisconsin are now measuring with peripheral arterial tonometry and Bluetooth heart rate sensors in a researcher-blinded crossover trial. He was targeting the same nerve the Innovate-HF trial targeted with a titanium electrode and $40,000 of surgical infrastructure. He just used a hymn instead. The nerve has been mapped. The resonance frequency has been identified. The vascular response has been quantified. The pharmaceutical comparison has been drawn and honestly calibrated. And the simplest, cheapest, oldest method of stimulating the vagus nerve is the same thing that has been echoing through kitchens and churches and open fields since before anyone thought to write it down. You already own the mechanism. You have been carrying it your entire life. Sing one note. Hold it. Feel what happens behind your ribs. Now tell me, what was the last song you sang without thinking about why it made you feel the way it did?